Good afternoon, good evening, good morning to everyone, and welcome to this series of SSNC Strengthening Series seminars. We will be having the first one today, and because this is our first meeting with the mentors, especially those mentors who've joined phase 2, we will also have an introduction of the mentors. We'll take the first few minutes of this time to get to knowing each one of you. But we'll run it, I will let you know when and how we could do the introduction. This is the agenda. We have the welcome by Dr. Aisha DeCosta from WHO. Then we have the introduction of the participants, the seminar taken by Dr. Suman Rao, and there are a few poll questions, followed by a brief on the tools for which are based on this particular seminar itself. We have 2 tools as part of phase 2 for strengthening of small and sick newborn care. And those tools, very briefly, will describe what we would be needing to do as mentors. Over to you, Dr. Aisha.
Thanks very much, Marianne. So on behalf of the Newborn and Child Health Unit at WHO headquarters in Geneva, I would like to welcome each and every one of you. I know that you are all senior practicing clinicians who have taken time out of your busy schedules, and WHO appreciates this time that you are giving us. Now, just a bit of background on why we are having this set of mentorship seminars. We are actually at WHO have been thinking about preterm mortality and the importance of preterms contributing to neonatal mortality. It is the #1 cause of neonatal mortality. And one of the lacunae that we see in health systems is actually the difficulty with preterm survival at district level SNCUs or district level units. And so one of the strategies that we would like to introduce is actually mentoring of district level mid-career professionals in the SNCU to promote preterm survival. And so we have approached each of your countries, your ministries of health, to actually help us identify the neonatologists of national repute who can be mentors to these district level units to help us improve preterm newborn survival. So each of you have been recommended or seconded by your ministries of health on the basis of your seniority and your expertise and experience, knowledge of your country context, and the influence that you wield with the clinical community and your professional societies. Again, very deep thanks and gratitude from WHO for your presence here today. This is not a teaching session on clinical neonatology. You are all too far experienced and too much of experts. You could probably teach us instead. The reason we want to have these sessions is really to focus on what are the key concepts that we would like as WHO for you to expand upon with your district level units. So the idea is really not a clinical teaching session in neonatology, but really to prepare you to be mentors in those key concepts that we think that the unit staff could be mentored in to promote preterm survival. So with that said, this is not about you are all worldwide experts. This is not about teaching clinical neonatology. This is really about preparing you to be mentors in the context of the WHO-led multi-country project in district level small and sick newborn care units. Once again, a very warm welcome to you from the Newborn and Child Health Unit at WHO headquarters in Geneva, and we look forward to working with you over the next couple of weeks. Thanks all. Over to you, Marianne, to take us through the agenda.
Yeah, thank you, Dr. Aisha. And now we would go into the introduction of the participants. I will just share my screen again, sorry. We will go one by one. We'll first have the Nigeria team. Can I request, as I read out the names, if you are present, please put on your video and just introduce yourselves. Probably I'll stop sharing and I'll call out the list of names so that it's easier for you all to be able to to be able to introduce yourselves. Please unmute yourselves as well as put on your video so that we can see you and we get to knowing you in this mode. Okay. So the first one is Dr. Xiaomi. Dr. Xiaomi is there? Okay. The Nigeria team, Dr. Aide, would you want to do the introductions for your team members if that works faster? Dr. Aide?
Aide, you muted. You muted.
Oh, so sorry. So I can do it.
Oh, so sorry.
So
I can do it. So
why is it echoing?
why is it going?
And I'm the only one here. Don't know why it's echoing. But let me just quickly start. I'm Ayede Adejumoke Idowu, a neonatologist based in USH, Nigeria. I coordinate the preterm sick and small newborn care project and ACS. Then I will just go through this. We actually have other names, so as I see them on this list.
Yes.
So we have Banke Oluwafemi. Please, as I call your name, just switch on your camera. Banke Oluwafemi, neonatologist for mother and child, Akure.
I'm here. Good morning, everyone. Good morning, Mas.
Good morning.
Good morning.
Good morning.
We have Dr. Ray from UCH, who is the national project coordinator, also a pediatrician. Dr. Ray, you can switch on your camera, please. We have Dr. Bukola Shayomi, a pediatrician neonatologist with Lautech Teaching Hospital. Bukola Shayomi is already in the meeting. I don't know why he's not switching off on his camera. Shayomi, can you switch on your camera and say hello to the audience? You can say hello even if your camera cannot be switched on.
Okay.
Just say hello to the audience.
We may have a
Even
connection problem, Aide.
Professor Iretiola Fajolu, a neonatologist based in Lagos University Teaching Hospital. Please, can you switch on your camera, Professor Fajolu?
Good morning, everyone. Well, you can see me. I don't know if my camera is on.
Yes, your camera is on. We can see you.
Okay.
Yes, we see
Good
you.
morning.
Welcome.
Good morning, everyone. Thank you.
Professor Lamidi Audu, based in Federal Teaching University Teaching Hospital, Azare, a neonatologist. Professor Audu.
Yeah, good morning, everyone.
Good,
Please, can you see me?
good morning.
Yes,
we can see you. Welcome.
Okay, good morning.
Thank you.
Happy to be here.
Thank you. Nice to have you.
Thank you.
Dr. Oladibu Olanike, a pediatrician neonatologist, also in Lautech Teaching Hospital, Ogbomoso. Can you switch on your camera? Just say hello, even if you cannot switch it on. Say hello to show that you are here.
Dr. Shayomi is here. Good afternoon, everyone.
Okay,
Good
thank you.
network.
Good afternoon.
Dr. Oyejoke Oyakwero, a pediatrician neonatologist with General Hospital Ikorodu. Can you switch on your camera and say hello?
Am I visible?
Dr.
Good afternoon, everyone.
Oyakwero.
Can you see me? Good afternoon.
Okay, thank you.
Good afternoon.
Dr. Ajibola Tajudeen, Dr. Ajibola Tajuddin.
Thank you. Fine. Thank you.
Good afternoon.
Good afternoon, everyone.
Okay, thank you. Dr. Sarah Ango from FMC, Nasarawa State, a neonatologist, actually our former NISOM secretary. Sarah Ango, can you please switch on your camera and say hello to the audience?
Salute. Captain, how are you?
Sarah Ango.
It's becoming bigger every day. You're a big man. Huh? No. Anna, thank you. Yeah.
Professor Audu, you can mute yourself, please.
You have introduced
So
me already. I'm here.
I think we are okay. I might not have called everybody. The names keep going up
Good
and down.
afternoon.
Yeah. Thank you.
But
Thank you,
we
Dr.
are
Aide.
about
Yes.
we are about 22 here. We are supposed to be about 22. We added more names so that we have two mentors per state, minimum of 2 mentors per state. Thank you.
Thank you, Dr. Aide. It is so nice to meet each one of you, and we will look forward to working with each one of you. Now, can I request
Marianne,
if
Marianne, can we
yes?
just check that? Can we just check that everyone who's from the Nigeria team has been introduced? Is there anyone from the Nigeria team we haven't met?
Yes, I've seen one now. And
Yeah.
from Abakaliki, Pink Lady. Yeah, she's here. I just saw her now.
Yeah, good morning, everyone.
Okay,
I'm Lynn from Abakaliki. I just joined. I'm happy to be here. Thank you. Thank you, Prof.
Thank you. Welcome. Okay, Idea, I think we've gone through everyone in your team now, the Nigeria team. Back
Yes.
to Marianne.
Okay.
Back to Marianne.
Thank you, Aisha.
Thank you.
Can I request you to mute yourselves if you are not talking, please? Thank you. We move to the next team, the Ethiopia team. Can I request Dr. Gizet, if you're there, or Abby, if you're there, to introduce the mentors?
Good morning, good afternoon, everyone.
Yes. Good afternoon, Dr. Gizet. If you
Good
can put
afternoon.
your video on and then introduce the mentors from Ethiopia, it will be great. Thank you.
I think my camera is not working, but at least now are you hearing me? Like, just let me introduce my team from Ethiopia. So, as you know, just I'm Gaset Matafara from Ethiopia, and then small and signable lead for antenatal cost implementation study. So I'm going to call the name of the mentor. So when I call the mentor, please, the mentor can introduce yourself for the team. So the first one is Dr. Konjit from St. Paul Hospital. Konjit. Okay, Dr. Dajani. Dr. Dajani from Art Comprehensive Specialized Hospital. Dr. Dajani.
Hello.
Please introduce yourself.
Yeah, I'm Dr. Dajani from Ethiopia, one of the mentors. Nice to meet you all.
Welcome, Dr. Dejane.
Welcome.
Thank you.
Dr. Aschalo from Falaga Health Comprehensive Specialized Hospital.
Okay, good afternoon, everyone. I'm Dr. Aschalo from Ethiopia, Bahar Dar Falaga Health Comprehensive Specialized Hospital. I'm a mentor. Thank you.
Thank you, Dr. Aschalo.
Thank you.
Dr. Tagane
Welcome.
Bikila. Dr. Tagane Bikila, pediatrician neonatologist from Adama Hospital Medical College. Dr. Tagani.
Hello? Hello?
Hello, please introduce
Hello?
yourself, Dr. Tagani. Yeah, we are hearing you.
Okay. Okay, thank you. I am Tagene from Ethiopia. I'm a neonatologist and mentor working in Adama Hospital Medical College.
Welcome, Dr. Tegane.
Thank you.
Dr. Getaso from Hawassa, University Pediatricians from Hawassa Referral Hospital. Dr. Getaso, please introduce yourself. Okay, Dr. Mulu from Matukar Comprehensive Specialized Hospital. Please introduce yourself.
Dr. Muluz, okay.
Dr. Kiros from Aider Comprehensive Specialized Hospital. Dr. Kiros.
Hello, everybody. How are you? I'm Dr. Kiros from Meghalaya University, Aider Comprehensive Specialized Hospital, pediatrician working in neonatal ICU, and I am a mentor.
Welcome, Dr. Kiros.
Dr. Mazgabu from Makale General Hospital, pediatrician. Dr. Mazgabu. Dr. Mazgabu. Dr. Zahara from Black Lion Hospital, Addis Ababa University, the neonatology fellow.
Hello, everybody. I'm Zahra from Addis Ababa University, Black Lion Hospital. I'm a pediatrician and a neonatology fellow currently. So nice to meet you, everybody.
Welcome. Welcome,
Hi.
Dr. Zara.
Good afternoon.
Anyone?
I'm Dr. Masgare from Makala General Hospital, pediatrician.
Welcome.
Welcome, Dr. Meskebe.
Welcome.
Yeah, over to you. If you have anyone missed from Ethiopia, please introduce yourself. Anyone who didn't mention the name.
Okay, hello everybody. I'm Dr. Makwan from Ethiopia, working in one of the general hospitals, in Jubara General Hospital. I'm a pediatrician working in the neonatal ICU, and I'm a mentor.
Welcome, Dr. Mekon.
Anyone,
Thank you,
please
Dr.
introduce
Gezet.
yourself.
Yeah, I think you went through the list and everyone, all the names I think have been read out. Thank you and welcome to the group, all of you mentors from Ethiopia, and would be really looking forward to working with each one of you. Now, can I call Professor Shahidullah if he's there, or Dr. Sabir to introduce the Bangladesh team, please? This is a long list.
Sabir, are you going to do that or with me?
Sir, I will do that, sir.
Okay, do it for me.
Okay, thank you, sir. Professor Shahidullah sir is here. Professor Shahidullah sir is the leading the Bangladesh team, and we also have the master mentors. Will come later then with their introduction. But first of all, I'll request Dr. Sumaita, who is the SSNC focal point, to go through the list of the master trainers. Most of them are already here. Some of them are struggling with the internet connectivity, but she will read out the name, and I'll request the master trainer, please open the camera if possible and introduce yourself and also in which hospital you are. So please, sir, introduce yourself when Sumaita will be read out the name. Thank you. Over to you, Sumaita, please.
Thank you, Dr. Sabir Bhai. Hello, everyone. This is Dr. Shumaita, SSNC lead from Bangladesh team. I will tell the name of our respected mentors. Dr. Ruman ma'am from Sir Solimullah Medical College. Ma'am, please introduce yourself. Then we have Dr. Debobroto Roy sir from Sir Solimullah Medical College.
Okay, next.
Dr.
Next.
Sumeta,
We have
if you
Dr.
can move forward. Yes.
Yeah, Dr. Tariqul Islam sir from Sir Solimullah Medical College. Dr.
Good afternoon. Good afternoon. This is Dr. Tariqul Islam. I am working as an associate professor at Sir Solimullah Medical College, Dhaka. Thank you.
Welcome, Dr. Tariqul.
Thank you, sir. Next, we have Dr. Shamim Hussain sir from Sir Solimullah Medical College. Next, we have Dr. Shahzadi Nasrin ma'am from Sir Solimullah Medical College. Next, we have Dr. Afroza Islam Shuma ma'am from Dhaka Medical College. Next, we have Dr. Jasmine Akhtar ma'am from Dhaka Medical College.
Hello, everyone.
Next, we have
Sorry, Dr. Shumaita. Dr. Jasmine, I think, is speaking, but the microphone was off. Yes.
Jasmine, now
Yes.
you are in my.
Good afternoon. I am Professor Dr. Jasmine Akhtar, working as a professor of neonatology at Dhaka Medical College. I am also a mentor of this startup.
Welcome, Dr. Jasmine.
Hello, everyone. Good afternoon. I'm Dr. Afroza Islam Shuma, working as Dhaka Medical College Hospital as an assistant professor of Department of Neonatology. I'm happy to be here. Thank you.
Thank you,
Welcome,
Dr. Afroza. Welcome.
Thank you, ma'am. Next, we have Dr. Niyamot sir from Shohid Sohrawardi Medical College. Then we have Dr. Humayun Shikdar sir from Shohid Sohrawardi Medical College. Then we have Dr. Mohsina Afrin ma'am from Mugda Medical College. Then we have Dr. Jahanara Parveen ma'am from Mugda Medical College.
Can I say one thing? Just Sumaita. Those from Bangladesh
Yes.
team, can you just switch on your video and unmute yourself so that you don't need to waste your time to introduce? So all of you, you can switch on the video and also the you can unmute, and then after introduction, you just switch off both of them. Go ahead, Sumaita.
Hello everyone. This is Dr. Jahanara Parveen. I'm working in Mugda Medical College Hospital as consultant of pediatrics and neonatology. I'm happy to be part of this team. Thank you very much.
Welcome, Dr. Jana.
Thank you, ma'am.
Hello. Hello, this is Dr. Liton Chandra Saha, working as an associate professor in Bangladesh Shishu Hospital and Institute, and happy to be here as a mentor. Thank you, sir.
Good to meet you again, Dr. Liton. Welcome to the team. Yeah.
Hello, Assalamu alaikum, and good afternoon to you all. I'm Dr. Kanta Chaudhary, working as an assistant professor in the Department of Neonatology, Bangladesh Shishu Hospital and Institute. I'm very glad to see you all. Thank you.
Welcome, Dr.
Good
Kanta.
afternoon. I'm Dr. Mahbooba Akhtar, working in the Medical College Hospital as assistant professor of neonatology. Thank you for being here.
Thank you, Dr. Akhtar.
Hello everyone. Assalamu alaikum. I'm sorry, I'm Dr. Ruman, assistant professor, neonatologist at Solimullah Medical College. Sorry for the inconvenience previously.
Welcome, Dr. Ruman.
Welcome.
Hello everyone, I'm Dr. Humaira Akhtar from Chittagong Medical College, Bangladesh.
Really grateful to be a part of this team. Thank you.
Welcome,
Thank you.
Humaira.
Devashish.
Hello everyone. Assalamu alaikum. Have a good day. Me, Dr. Devashish Saha, working as an assistant professor in Bangladesh Medical University, Bangladesh. Thank you.
Welcome, Dr. Devashish.
Assalamu alaikum. Me, Nadia Hussain, working as a neonatologist, assistant professor in neonatology department, Maniganj Medical College Hospital, Bangladesh. Thank you.
Thank you,
Hello
Dr.
everyone,
Nadia.
this
Welcome.
is Professor Mannan. I'm working as a professor and chairman, Bangladesh Medical University.
Welcome, Dr. Manna.
Welcome, Professor Honan. Good to see you.
I can see Rajak Bhai. Dr. Rajak Bhai, please.
Assalamu
Hello
alaikum.
everyone.
Hello everyone. This is
Assalamu
Dr.
alaikum.
Alpana Jahan.
Yes.
Sorry.
Okay.
Sorry for
Yeah,
interrupting.
Rajak Bhai, let Alpana madam, let introduce, then you
Yes.
probably. Alpana
Thank you,
madam,
sir.
please.
This is Dr. Alpana Jahan. Hello everyone. Working as an assistant professor in Dr. M.R. Khan Shishu Hospital and Institute of Child Health. Thank you, my all mentors, for making a part of this program. Thank you.
Rajak Bhai,
Welcome,
you can
Dr.
go on.
Alpana.
You're welcome.
Dr. Arif is there.
Hello everyone, very good afternoon. This is Dr. Arif, neonatal specialist working at Bangladesh Medical University. Thank you for having me here and happy to see you all. Thank you.
Welcome, Dr. Arif.
I think that's most of us. And some of
Hello.
them.
Hello everyone.
Hello, please.
Assalamu alaikum.
Good
I am Dr.
afternoon.
Sultana Jahan, working as registrar in Sylhet
Hello,
MH
good
Osmani
afternoon.
Medical College. I am proud to be here. Thank you.
Welcome, Dr. Sultana. Is there
Hello, good
anyone
afternoon.
else left?
Hello,
Yes.
good afternoon. This is Dr. Sadika Choudhury from Department of Neonatology, Bangladesh Medical University, working as associate professor. Very much pleased to get introduced with this big team.
Welcome,
Welcome,
Dr.
Dr.
Sadika.
Sadika. Welcome, Dr. Sadika.
Everyone, this is Sanjay Kumarte. I am working as professor in neonatology in Department of Neonatology, Bangladesh Medical University. Nice to see you.
Okay.
Hello, good
Welcome,
afternoon.
Professor
Welcome,
Sanjay.
Professor Sanjay. Good to see you.
Hello, good afternoon. I'm
Yes.
Dr. Sharburi Saha, working as assistant professor, Department of Neonatology, Bangladesh Medical University. Thank you, all my mentors, to adding me in this program. And good to see you all.
I
Thank
see
you.
Dia and
Hello.
also Rumpa.
Dr. Sarbari.
Hello everyone. Good afternoon. I am Dr. Rumpamani Choudhury, working as an assistant professor, Department of Neonatology, Bangladesh Medical University. Nice to see you all.
Welcome,
Welcome.
Dr. Rumpa.
Elvia Jahan.
Assalamu alaikum. I'm Dr. Ilbia Jahan, working as registrar in Institute of Child and Mother Health, ICMED. Thank you.
Welcome.
So we have today our study physician, but they are observer participants. So other than the study physician, any one of the master trainers, if we missed, please introduce yourself from Bangladesh. I think others, if they join, they will introduce. We can proceed. Over to you.
Thank you.
Thank you.
Thank you, Dr. Sabir and Dr. Sumiyata for helping out with the introductions, and Professor Shahidullah as well. We go now to the last site team, that is Pakistan. Pakistan team is Alfur there. Alfur, will you be to the introductions, or Dr. Rehan is available? I can't see the list.
Yes, I think Dr. Rehan is in the meeting as well.
No, I am
Okay.
available and
Yes.
I am there.
Right.
Nice to meet you,
So,
sir. So if you can do the honors, please, of
yeah, no,
introducing the
that's
mentors.
fantastic. Thank you very much. So what I want from the Pakistan side is that you all know that they are all the neonatologists working in different provinces. So just to minimize the disruption, what I will do is that the ones who are from Punjab, they'll do their introduction first, then the people from Sindh, then the federal, and then the rest of you can introduce yourself. Just say your name and give a pleasant smile to them. And that's it. That's all we want. So starting from Punjab, Sindh, and then federal, and then anybody else who's present. And I'm going to shut off my mic so that will minimize disruption. Thank you very much.
Thank you, Dr. Rehan.
Assalamu alaikum. Good evening, everyone. My name is Dr. Aun from HSA Pakistan. I'm so glad to be a part of this. Thank you.
Welcome, Dr. Om.
Doctor, I will just call out
Go
Dr.
on,
Kaleem.
next. Go on.
Dr. Kaleem. Yeah.
Assalamu alaikum wa rahmatullahi wa barakatuh, and very good afternoon. It is good to see you all. I am Dr. Kaleem Akhtar Malli, consultant neonatologist working at a private sector in Lahore, and it is an honor to be a part of this August team. Thank you.
Next from Punjab.
Welcome.
I'm Dr. Sadia Yasmin. I'm working as neonatologist at Fatma Jinnah Medical University, and I'm really ambitious to work with this team.
Welcome, Dr. Sadia.
Next.
Ji, Sikandar Ayad, Associate Professor in Neonatology from Lahore. Thank you.
Next.
Welcome.
Go on, Azim. If there is nobody from Punjab, then Azim, you go on. Okay. Anybody else from Sindh?
Good evening, everyone. I'm Dr. Faraz Ahmed, and I'm working as Assistant Professor in Neonatology at Sindh Institute of Child Health and Neonatology, Sindh. Thank you.
Next.
Welcome.
Welcome, Faraz. Good afternoon. I am Dr. Mohammad Usman, working as an Assistant Professor of Neonatology at Association, Sindh, Pakistan.
Thank you, Usman. Next.
Welcome.
Welcome.
Okay, we will move on to federal. Anybody from federal?
Good evening, everybody. Assalamu alaikum. I am Dr. Amna. I'm working as a senior registrar neonatology, PIMS Hospital, Pakistan. And I am
Thank
very
you,
happy with
Amna.
all of you. Thank you.
Thank you very much. Anybody else from federal?
Welcome.
Assalamualaikum. Assalamualaikum. I'm Dr. Nagam from PIMS Hospital, working as a neonatologist.
Excellent,
Welcome.
Nagam. Thank you. Anybody else?
Assalamualaikum. I am Dr. Leela Riaz, working as a registrar in NSU at Maruf International Hospital, Islamabad.
Thank you,
Welcome.
Adila.
Welcome.
Next. Anybody from KPK? Okay.
Anyone from
anyway,
Khyber?
I think Alf will provide you the list of all the mentors.
Sure.
Then we'll just move on with your next team. If anybody else is there from Pakistan, please speak up now. That's it from my side, Aisha and Suman. Thank you very much.
Thank you, Rehan. Thanks.
Thank you.
Marianne?
Yes.
Marianne, would you mind if I just spent a minute introducing the project and the WHO team? Because I just realized that many of the mentors are new and I'm meeting them at least for the first time. So
sure.
I just wanted to address all the team of very august mentors that are gathered here on behalf of WHO, the Newborn and Child Health Unit at headquarters in Geneva. Thank you all very much for giving your time towards this endeavor. Very briefly, WHO is coordinating this multi-country project in Ethiopia, Bangladesh, Nigeria, and Pakistan on improving preterm birth survival. Given that preterm birth is the #1 cause of neonatal and child mortality, and one of the gaps that we've seen in our health systems in low middle income countries is that we often have excellent facilities at tertiary level. Our tertiary NICUs, our teaching hospital NICUs are very good and able to manage, but we have a lacuna when it comes to the district level special newborn care units. So the idea here is actually to be able to strengthen the district level small and sick newborn care, particularly for preterms. And for this purpose, we had approached the ministries of health in these countries to provide us academic neonatologists from the university hospitals of national repute who can serve as mentors to help mid-career professionals build up competencies in preterm birth survival in the neonatal intensive care units in the district. So the reason we're going to have this series of seminars is really not as a teaching session for all of you, but really because you can actually teach us. But it is really to think about what it is we want to focus on when mentoring mid-career professionals in preterm birth care. Mentoring mid-career professionals is very different from teaching residents or teaching students. It requires a different approach, a different emphasis, and looking at different aspects of care for people who are experienced with delivering that kind of care. So with just that background, again, a very warm welcome to all of you from headquarters in Geneva. And we're going to look forward to working with you, not just over these seminars, but over the course of the coming year as this project takes shape. Thank you to all the coordinators from the different countries who helped us assemble the teams as well. From the WHO side, I'd like to introduce our team that will be working more closely with you. Could I just call on Dr. Rosa Flavia?
Yes, thank you, Aisha. Good afternoon and morning for some of you. Thank you so much for being here. I'm Flavia Mangeret. I'm a neonatologist, consultant in Geneva University Hospitals, and I'm consultant for neonatology for WHO. We'll be seeing ourselves each other a lot in the next months.
Thank you, Flavia. Dr. Suman Rao?
Hello, everyone. I'm Suman Rao. I'm a professor of neonatology at St. John's Medical College Hospital, Bangalore, and I've been a consultant with WHO for the past 9 years and also been part of this project since its inception. Thank you, and hello to all our friends. It's nice to meet you all again, even though it's virtual, and hello to all the new mentors who have come on board.
Thank you so much. Dr. Marianne? Dr. Marianne? I don't hear Marianne, but Marianne is another member of the WHO team who specifically works with middle-income countries and is supporting this particular project. On behalf of WHO, very warm welcome to all of you and looking forward to walking this journey with all of you as we learn together on what it takes to strengthen district health systems to provide SNCU care for preterms. Very welcome to all. Back to you, Marianne.
Yeah, thank you, Aisha. Over to you, Suman, now for the seminar, which Dr. Suman will be taking, which is Care at Birth. We basically have 8 seminars, and this follows the 8 domains of small and sick newborn care. So the first of the series will be Care at Birth, which Dr. Suman will take. Over to you, Doctor.
Yeah, good morning, good afternoon, good evening to all of you all again. And so we have spent some considerable time on the introduction, but we think it's absolutely important that we did it. even though it means that the time for this actual seminar is lower, we are quite happy with it, because as Aisha has been saying, this is not a teaching session at all. These are a series to just make sure that all of us are on the same board, and some key messages are being given in the same way in all the countries across. So that's the reason why we are meeting together virtually, and we are setting the stage for the actual implementation. In these series of 8 seminars, we will not be discussing mentoring. That will happen in in-person meeting. We will be mainly discussing on the content of the domains to ensure that we're all on the same page. So it's more of a discussion rather than a session. And we would definitely invite your participation in this, the mentors, to share your thoughts, to share your practices, and maybe to iron out a few differences if there are any. And today's topic, we'll start right at the beginning, and that is care at birth. I would like to not take more than 20 minutes for this so that we have some time for discussion. But considering that we have spent some time, if the discussion spills over to the next session, that's absolutely fine. So please do continue to put your clarifications, queries, or anything else that you might differ in the practices in the chat. If at all we don't have time for it at the end. So let's start with care at birth. And this is the first of the small and sick newborn care strengthening series. And as we all know, the first step is being prepared. And then we talk about what we should be doing routinely for every newborn, including skin-to-skin care, delayed cord clamping, breastfeeding initiation, birth defect screening. We'll spend a little time on refreshing on the most important aspect of newborn resuscitation, that's ventilation, and then look at which are the babies which go into this for the small and for the SNCU care, and a bit on safe transport. So this is something I keep reminding myself, because whenever there is a problem, it just means that we were not fully prepared. So failing to be prepared is preparing to fail. And when we say be prepared, we should be prepared as health personnel. We should be ready to resuscitate a baby. And every baby needs a trained health personnel at the time of delivery. And if it is a high-risk baby, then we need someone who can do the entire resuscitation, including up to endotracheal intubation and medication. So the health personnel should be ready, the equipment should be ready, and we need to ensure that the room is warm. We have the clothes, linen ready. The radiant warmer should be turned on at least for 20 minutes. So we are keen that every newborn corner, which are in all the network of care facilities, which are part of the study, have a radiant warmer, which is an essential part of resuscitation. We need to check equipment, and of course, we also need to introduce ourselves to the parents and ensure that there is proper documentation. My first thing is about safety. And we all know infection is a huge problem that we battle with, and sometimes it starts right in the delivery room. So let's not forget the 6 cleans of safe delivery are clean hands, clean surface, clean cloth, ensure that the mother's perineum is clean, clean cord tie, and clean cord care. And I'm sure all of you all are very familiar with this. It is the implementation that we need to ensure is done. The more that is said on hand washing, the more emphasis that we place on hand washing is still less, because it's finally what we do with our hands which determines the output. And therefore, we need to focus on hand washing even in the delivery room. In the delivery room, it's important that a newborn resuscitation algorithm is put up. It could be what you see on the left-hand side, this one, which is the Helping Babies Breathe algorithm, or it could be something like in our units, we use the AAP 2025 algorithm. It could be anything that your country, your units are following, but this algorithm should be put up in the newborn resuscitation corner. And we need to be able to identify which is the baby who requires resuscitation and which is the baby who requires routine care. So obviously, I think it's very clear from the photo which baby requires routine care. And let's look at what is the routine care that we will be doing. And the first thing is to wait for 1 full minute. And especially it is the obstetrician's time, which sometimes becomes more precious. So we need to ensure that our obstetricians wait for a full minute to clamp the cord. And during this time, the baby is placed on the mother's abdomen. We wait for 1 full minute and only then clamp the cord. So with this, I request Flavia, if you can go to the first poll that we have to understand the practices. So over to you.
Yes, so you might have received a question. Yeah. You might have received a question that appears on your screen right now. For those who don't see that question on your screen, you can see on the chat. The question is related to your practice on cord clamping. So you can answer basically based on what you do more often. Immediate cord clamping, it's number one. Number two actually is delayed cord clamping for term and preterm infants. Then we have cord milking, and then we have delayed cord clamping for term infants. So we have up to now 2 answers. You can just go and click on the answer and submit your vote. Again, you can do this either on the chat, either on your screen. We are seeing some answers now on the chat. We have one answer, immediate cord clamping, one answer, delayed cord clamping for term infants. And now we are trending up on delayed cord clamping for term and preterm infants. But so we all have 6 answers for that one. And then 2 more people answered number 3, which is delayed cord clamping for term and preterm infants. So most of the people are answering delayed cord clamping for babies.
So we would definitely like your very active participation, considering that we are more than 100 participants here. We would definitely want you all to participate more. Because only by knowing what the practices are, we will be able to discuss more on it. So I think we will go on.
Can I ask one question? Can I ask one question?
Is it possible to just hold on to the questions till the end? Because I'm sure there are many, many questions which will come up. And if sometimes we are worried that we will forget the question, I would suggest that you just put it into the chat and we will address all the questions. I'm sorry, but with more than 100 participants, sometimes it may be difficult if everyone has questions, but we'll definitely take it up now. So Flavia, would you like to tell us what is the final thing on the poll?
So the final poll, we have 77% of the answers on delayed cord clamping for term and preterm infants, but we have quite a few answers below the poll that are also answering the same thing. So it's basically the majority, vast majority answering delayed cord clamping for term and preterm infants. So I would just ask also for if you can, when you answer, if you could just click on the answer, it's easier for us to see the whole number of answers instead of replying on the chat. If you can't, please reply on the chat. That's also good. But if you can just check on the answer, that would be great.
Thank you, Flavia. So I think the first poll was a success, and we have almost all of them taking part in it. And very, very rightly, delayed cord clamping is recommended for both term and preterm infants. But even the 15% who have said immediate cord clamping are not wrong, because when a baby, it doesn't cry at birth, then yes, we still do immediate cord clamping and take the baby for resuscitation. Cord milking is practiced in some places, but it's not a recommendation. So now let's look at why we need to do delayed cord clamping. And so here on the left-hand side of my screen, you see all the different benefits, starting from the mother for the full-term infant and including for the full preterm infant. But the most important thing, which you see on the right side, is about saving lives. Just a minute of delaying cord clamping reduces mortality, especially in preterm infants. So for us, in this antenatal corticosteroids implementation research, this is a very important intervention, which we would like all the sites to be practicing. So let's go forward now. After emphasizing on delayed cord clamping, the next thing is about skin-to-skin contact and zero separation. The recommendation is that all babies get skin-to-skin contact at birth for the first hour without any separation. So let's hear from you all your practices, and let's go to Flavia again for the second poll.
Yes, so the second poll you will see on your screen also, it's concerning skin-to-skin contact. For which babies do you provide skin-to-skin contact at birth? So answer number 1 would be term infants born from vaginal delivery. Answer 2 will be term infants born from cesarean section and vaginal delivery. Answer 3 would be all, except for twins. And answer 4 will be all, except for sick babies on CPAP. So we are having some answers. We have 2 answers only up to now. So I think we can wait a little bit more. You can answer on your screen, and you can also answer on the chat. But on the poll on the chat, please, if you can do that, that would be great. So we have most people answering all except the sick babies on CPAP. And 30% with term infants born vaginal delivery, 9% term infants born by cesarean section and vaginal delivery, and nobody answered all except twins. Yeah, most of the answers, vast majority now are 75%, all except sick babies on CPAP. And we have quite a few that are on the chat, also that one. So that's the winner.
Thanks so much. Thanks again, Flavia. And I think, yes, this is something, it is a recommendation, but I know it's quite challenging to implement it for the full hour, but this is something that we need to try. So skin to skin contact, definitely for the vaginal delivery babies, but it is important that we try to do it even for the babies who are born by cesarean section, as you see here. Sometimes you may have to change the position that you do it when you're doing it for a C-section baby. Here you actually see twins and born out of cesarean section getting kangaroo mother, skin to skin contact. And here you have a sick baby who is on CPAP, is a preterm, who is also getting the benefits of skin to skin contact. So there is actually um, no contraindication to do skin to skin contact for any baby. It is only the implementation which is a challenge. So when we look at the benefits, what we see here are all the benefits that is mentioned in the Cochrane meta-analysis. It helps the baby do the transition. It promotes breastfeeding in a big way. And very importantly, it also promotes a baby's neurobehavioral development and organization. And these benefits are seen as late as 10 years or even later. And this is a slide from the Essential Newborn Care module of WHO, which tells us that if we do not practice uninterrupted skin to skin, what may be the consequences? And that is something we need to remember, that not doing something good may also be harmful. So let's focus on skin to skin contact. And that's the second recommendation that we would like to emphasize as part of care at birth. And then we know that breastfeeding, in fact, skin to skin contact is the way through which breastfeeding is initiated. And here you see a serial pictures of how a baby is doing the breast crawl and reaching the target of the breasts of the mother to start and initiate breastfeeding. So we need not push a baby to initiate breastfeeding immediately after the baby is put. Give the baby time and the baby will move towards the breast. And again, even for the small baby who is sick, we need to ensure that the breast milk gets into the baby in the golden hour. And here you see a baby who's in skin to skin contact in the KMC position. And you see a health worker who is drawing out the colostrum. And it sometimes comes in drops. And therefore, you may need a 1 cc syringe to do that. And that is being given to the small baby in skin to skin contact. So these are good practices that we would like to promote. And then, of course, all babies need a birth weight and injections like vitamin K, but these can wait. We are not in a hurry to do them. Let's give the first hour for zero separation and then go on to birth weight. And in all these clusters that we are going to be working in, birth weight training has already happened, and therefore rounding and heaping, which we sometimes see, more weights are being recorded as 2.53, 3.5 kg, all those are much better now after the birth weight training. So these are the routine things we do. In addition, a complete examination is a must. Birth defect screening is important. And you pick up a lot of these things directly in the labor room, and we need to do a complete examination to rule out something like a tracheoesophageal fistula, diaphragmatic hernia, ambiguous genitalia, and you have eye abnormalities, imperforate anus, neural tube defects, and the cleft palate are all seen here. So don't miss the areas like the eyes, the palate, and the back, which may show some birth defects. And every newborn baby, even if the baby is absolutely normal, should have monitoring every 15 minutes, monitor the breathing, monitor the temperature, monitor the color of the baby. So this was about a normal baby who does not require resuscitation. There are some evidence-based practices which are a must, which is going to promote their health, and it's important we provide that. But what about a baby who is not crying? We know that 1 in 10 babies need ventilation. So for them, the current recommendation is yes, you take the baby, position under the radiant warmer, and you start resuscitation. Clear the airways, suction only if needed, not as a routine, and brief stimulation. But the most important focus that we need to do for this baby is to start ventilation, giving the breaths to the baby in the first golden minute. Give a breath and save a life. And this breath has to be efficacious. So there should be an improvement in heart rate and the chest rise when we give the breath. And therefore, when a chest is not rising, which happens commonly, what are the common things that is going wrong? We would again like to know from your practice. And this is going to be the third and the last poll. Over to you, Flavia.
So you see appearing on your screen now the final poll. The question is the most common reason for inadequate ventilation you see. 1 would be leak around the mask, 2, flexed position of the head, 3, secretions, or 4, stiff lungs. So we'll wait a little bit for your answers. We have 1 answer for leak around the mask. A few answers coming now. Secretions, leak around the mask. So we have 6 answers. So if you can go and submit your vote, it will be great.
Yeah.
So yeah, we have definitely most of the answers are leak around the mask. We have 10, 11, 12, 13 answers on leak around the mask. 3 answers of flexed position, and a few more answers of secretions are coming up. It's becoming disputed, but definitely we're on 70% on leak around the mask.
Yeah. Thanks, Flavia. So in this question, there's no right or wrong. It's just your experience. For example, even for me, I think the leak around the mask is the commonest problem that I see when a baby is not having chest rise, but it could be the others based on your experience. So the most important aspect when we have a baby who is not breathing is to start ventilation in the golden minute. Ventilation is the most important aspect of resuscitation. It's not chest compression, it's not anything else. And therefore, we need a bag and mask or a T-piece, and we need to give it at least 30 to 60 breaths per minute. And for term babies, for all babies more than 35 weeks, it is room air resuscitation. Oxygen is a drug, and we do not use it unless it is needed. Now, for babies, and this is from the latest ILCOR guidelines, that for babies between 30 to 34 weeks, start between 21 to 30%, and for babies less than 32 weeks, you start more than 30%. Now, if there is no chest rise, look at, is the mask applied well? Is the position correct? Is the neck like in a sniffing position? You might have to do suction and clear the airway. Make sure the mouth is open wide and look at whether you need to give more pressure. Is the pressure adequate? And lastly, if nothing of this is working, consider an intubation or even a laryngeal mask airway. So this, I'm sure, reminds you of Mr. Soper. We used to go in that order before, but now the new recommendations are that you just have to see what is going wrong and correct that. You don't have to follow the sequence of Mr. Soper. So once you do effective ventilation, monitor the baby every 30 seconds. And for that, the heart rate is the best indicator that our resuscitation is going well. And for this, use a stethoscope rather than the umbilical pulsations. And if after 30 seconds, if the baby's heart rate is less than 60 after adequate ventilation, that's the time to start chest compression at a ratio of 3:1. And after another minute of cardiac compression and effective ventilation, only then consider giving drugs like adrenaline by putting in a UVC. But please remember that both chest compression and medication, very, very, very few babies need. In my unit, we had only around 2 babies needing chest compression, and this in the whole of last year. So if we can do our initial steps well, our ventilation well, very few babies need chest compression and medication. And if, again, when to stop, this may be based on local guidelines. The recommendation is if the baby's heart rate doesn't improve and there's no response, even after 10 minutes of adequate resuscitation, there's no heart, then we could consider in stopping ventilation. But again, let me reinforce, this is a skill that you as mentors need to ensure that all of them who are taking care of babies in the labor room know to give a breath to the baby to save the baby's life. And once all this is done, we need to identify the babies from the delivery room who need to go to the SNCU. You will have country cutoffs. It could be a birth weight less than 1.8 in your country or less than 2 kgs. The gestational age cutoffs may be there in your, which is different from this. And the babies may have problems like asphyxia, respiratory distress when you monitor, and these babies all need to go to the SNCU. And when we transfer them, we might have to use CPAP because, and there is a big focus on CPAP as part of this antenatal corticosteroids implementation research. And the CPAP could start even in the delivery room. So any labored breathing in very preterm infants, the babies may need CPAP right in the delivery room. And CPAP is a separate module, so I'm not going to go into it today, but we will have a lot of discussion and mentoring around CPAP. Transport to the SNCU is very important, and we prefer to do it in skin-to-skin contact. You see mothers or a caregiver who are taking the baby to the SNCU in skin-to-skin contact to ensure temperature. And temperature on arrival in the SNCU is a quality indicator. And in fact, admission hypothermia has been known to increase mortality. So there's a lot of focus on transport to SNCU, and it's important that a health worker accompanies the baby. And again, referral slips and all have made a difference from our phase 1. We have seen that these are important interventions to do. And once the baby comes to the SNCU, the admission temperature should be checked because this tells us how care at birth was and also helps us in prognosticating for the baby. Lastly, let's not forget about respectful care. Communication with the family is important. We need to talk to them. We need to talk to the mother. And that brings me to the last slide. The key messages, the focus in care at birth is on thermal control, establishing ventilation in the golden minute, delayed cord clamping, skin-to-skin contact for all babies, sick and otherwise, and breastfeeding in the golden hour, and finally, safe transport. So I conclude my presentation, and I do think that we might have some time for discussion. So let's definitely take in a few questions now and then go to the next one. So Flavia, if you can moderate the questions, let's see if we can take some questions. We are a large group and we have a few hands up. So shall I start then? Maybe I think that's Professor Mannan.
We just had one question from the chat that was put there previously. Would like to answer that
Yes,
before?
let's start with that because I know we promised, I didn't get who it was, but yes, go ahead, Flavia, to ask the question from the chat.
Let me just try to find it again. It was a question, should we provide the skin-to-skin care in very preterm babies?
Yeah. So skin-to-skin contact in very preterm babies is also recommended because we are in the recommendation by WHO is to start immediate kangaroo mother care for these babies as soon as possible. Yes, it is a skill to provide, CPAP and all in skin-to-skin contact. And then to move the baby to the SNCU, the skin to skin, the baby may have to move from the mother's chest to a caregiver's chest because the mother may still not be ready to move to the SNCU. So yes, short answer, very preterm infants, skin to skin contact is also indicated.
Yes, Dr. Kiros says that, but IKMC protocols currently are recommending even sick babies on CPAP to start them on skin-to-skin contact skin care.
Yes,
So
yes,
it's just
yes.
reinforcing the message. Yeah.
Absolutely.
So these were, I think, the two. There are a few more that came after, but I think the hands came first. So we can go for the hands first. Dr. Sajia Yasmin is the first one.
I want to ask that in one of the slides, it was written the stop resuscitation after 10 minutes if there is no heart rate. But when we look on the all the guidelines, they say that stop resuscitation after 20 minutes. So why is this difference here mentioned?
Yeah. So these are all individual, national protocols that you need to see. If there's absolutely no heart rate after 10 minutes, then the outcomes in these babies may not be good. So you need to look at your individual national protocols before you make these suggestions.
Okay.
And we are talking about no heart for 10 minutes. So asystole.
Okay, next one is Dr. Getasu.
Okay, thank you. Good afternoon, good morning, everyone. So my question is with regard to umbilical cord milking. So the recommendation with different guidelines or experts say that in preterm babies like less than 34 weeks and above 28 weeks of gestation, who needs resuscitation, I think some recommend this umbilical cord milking. So what is your opinion on this suggestions? Thank you.
Dr. Getasu, you have asked a very, very hot question. I think placental transfusion and umbilical cord milking and deferred cord clamping is some of the most hottest topic currently. There's a lot of research happening, and the latest ILCOR guidelines also talk about cord milking, intact cord milking for babies whom we are unable to do delayed cord clamping, like the babies who need resuscitation. But it should not be done for babies who are less than 28 weeks because it has been shown to increase intracranial bleeds. So in my unit, we use cord milking for babies. We need to resuscitate, and therefore we are not able to do the delayed cord clamping. But again, as I said, this is a very hot topic, and people are moving.
We
So
lost
as you
Suman.
said, it's a hot topic. Hello?
Yes, I think we lost you for a
lost
few
you.
seconds.
For a second, okay.
But I think the message is there.
It's clear. Okay.
Yeah, we can go to
We'll
Dr.
go to the next one.
Chioma.
Yeah.
Yes.
Okay, good afternoon, everyone from my end. My question is, from experience, we've noticed that most mothers don't lactate within the first 24 to 48 hours after delivery. So what do we do concerning the breast milk for these babies when they are born? That's my question. Thank you.
So thank you. I think if I got the question right, your question was that most mothers don't lactate in the first 24 hours after birth. And therefore, what do we do in such babies? Now, for a normal baby who is a term baby who is well, there's absolutely no problem. The baby has the reserves, and more important, that the baby suckles at the breast, and the coming in of milk may take a little longer. The more the baby suckles, the coming in will be good. So for a normal baby, we are not concerned that the milk coming out takes time. Now, for a small baby who is in the SNCU, we have seen that expressing breast milk with, this colostrum and using the syringe technique helps the mothers in lactating early. So even the smallest baby should be given an opportunity to suckle at the mother's breast. But in the unit, such small babies who may not have, may also
It's interrupted.
Okay, we lost someone again. Someone, I think she's back.
Yeah, we can't hear.
Right.
amounts, like say 30 per kg if it's a very small child. And in such babies, they are able to produce so much. So I think it is still possible to do exclusive breastfeeding and start feeding early, even for small babies in the SNC.
Suman, we lost you again for a little bit of longer time. I was wondering if maybe we could stop the camera.
Okay, I'll do that.
It'd be easier.
Yeah.
Next one is Professor Manan.
Yeah, thank you very much, Simone. My query is, are you recommending plastic bag for preterm babies less than 32 weeks of birth, gestational age? And second thing is, in terms of zero separation, how long the baby should keep with mother's skin to skin? Is it 1 hour, 90 minutes, or 2 hours? And third is, in terms of delayed cord clamping, what should be the position of the baby? The baby should be on mother's abdomen or below the abdomen level. So these three questions from my sides.
Okay. So thank you. You have asked many questions, and coming to the plastic wraps less than 32 weeks, it's a recommendation by ILCOR. As far as WHO is concerned, it is not recommending plastic wraps, but we are in the process of looking at our resuscitation guidelines, and this may be addressed again there. But even 2025 ILCOR guidelines recommend plastic wraps for less than 32 weeks. Now, the second question is on skin-to-skin contact, how long it should be. Yes, the recommendation is at least for the first hour, there should be zero separation. If you see our essential newborn care modules, we say 90 minutes because longer is better. So in fact, even for a term baby, if you can keep them in zero separation for a longer time, it is helpful. Now, coming to a preterm low birth weight infant, the skin-to-skin contact which you start off in the labor room should continue as kangaroo mother care for prolonged periods of time. So don't do less than 1 hour, but I agree with you that there are guidelines which also says 90 minutes. Now to your last question, please remind me that again. It was about where to keep the baby for
delayed cord clamping.
Delayed cord clamping. Actually, as far as I know, it doesn't make a difference because it's the pulsations which drive. Sorry, I think I was muted. So there is no recommendation to keep the baby below because it's the pulsations which drive. So we recommend that you put the baby on the mother's abdomen and wait for a minute and then clamp the cord. So I hope I've answered all your three questions. Was I audible? Am I lost?
Yes, that's all good, Suman. Thank you. We have the next hand is Dr. Tejani. Please go ahead, Dr. Tejani.
Dr. Tejani is muted.
Tagani, Dr. Tagani.
I don't know. Hello.
Yes, we can hear you.
Good afternoon. Thank you very much. My question is regarding the neonatal resuscitation, especially the first 1 minute, the golden minute. Once we started the ventilation, because that is the single most important in neonatal resuscitation, then if the baby is not improving with breathing, we have to, at least the next step is improve the ventilation. So to do that improved ventilation, the Mr. SOPA, this acronym, is that a must to follow these steps strictly, or we have to use only the opportunities to at least to help the baby? That means, for example, with Mr. Sopa, mask repositioning, a mask adjustment, secretion, opening the mouth, pressure, and alternative.
Yeah, so if I may answer that, Dr. Tejini.
Okay.
So it used to be
না শুধু
recommended.
কোনো সাজেশন এটা কি সবসময় সাজানো থাকে নাকি তোমাদের ইয়ে উপলক্ষে সাজাচ্ছে তোমাদের প্রোগ্রাম উপলক্ষে সাজাচ্ছে
Flavia, if you can mute
I will just check.
the background noise. Yeah. So Dr. Tejini, this Mr. SOFA used to be a guidelines as per the AAP and NRP protocol. But in the 9th edition now, it's very clearly mentioned that we do not need to go in the order of Mr. SOPA. You need to identify what the problem is and address that. But this mnemonic is still useful to think of what all the problems could be, but we do not have to go in the sequence which is mentioned in Mr. SOPA. Over.
Right. So,
yeah,
it was our last question.
Right?
No, and I think all the questions in the chat have been answered also. Yeah, so I think we are good with the questions. We are 5 minutes past time. We have Professor Manal that has the hand up again. Maybe we can have a last one. That's another hand maybe.
No,
Right.
Professor, I think we need some glitch there because sir is
hello, Roja.
Yeah, we can hear you
I have
now.
one comments. Yeah, I have one comments about the continuation of resuscitation. So I think I would request here Aisha, Simone, then Rosa, and Mary, and our respected teachers and also seniors. Can we make a recommendation from your side how long we should continue the resuscitation when we are not getting any heart rate or any kind of respiration and color is already blue? As because NRP, so far I know, is suggesting 20 minutes. So if we go country by country, sometimes it may be 10 minutes, 20 minutes, 30 minutes like that. So this is comments from my side. Over.
Thank you, Professor Mannan. I'm sure this also will be looked into because, as I said, WHO is looking at all the guidelines and we'll see what we can do about it. Yeah. So thank you all. Thank you very much. And we have our main, the national leaders here in neonatology, Professor Shahidullah, Dr. Rehan, Aide, Dr. Gesset, Dr. Aide. Thank you all very much for being part of this. If you all have any comments, please go ahead. Otherwise, I'll hand it over to Marianne for the last bit.
Marianne, if I may.
Yes, please go ahead.
We still have the job aids. Is it still, do you have some time to show them?
I think you can do that. Just might be, and I don't think we'll do the tools now because of the lack of time.
Yeah, I agree.
Yeah.
So just quickly, for each domain in SSNC, we have prepared job aids. These are not necessarily replacing what's already on the field, but for hospitals that don't have job aids in place during the strengthening phase, we are recommending that these job aids are used. So we will be introducing them to you during all the seminars, and we will also be working with them and teaching them when you are going to the sites and working with the champions and the teams. So this is the job aid for care at birth. It's care at birth and referral. So we have just one page with a few steps. So just reminders for the delivery room or the OT. Before birth, warm the room at least 25 to 28 degrees. Close the doors and windows to prevent wind and draft. Prepare clothing and linens, 2 sheets minimum, 1 to dry and 1 to cover. turn on radiant warmer on manual mode, and check resuscitation material, suction, ambu bag, mask, stethoscope, drug. So be prepared. Immediately after birth, so position on mother's abdomen, dry well with a clean warm sheet. For babies that have normal adaptation, they go through normal essential newborn care, delayed cord clamping, more than 1 to 3 minutes, skin to skin care for the first hour, for an hour, to be great. Breastfeeding within the first hours, no bathing, and vitamin K. For babies that are not breathing and have a heart rate less than 100, these babies will need resuscitation, so they will be moved to the radiant warmer. Start resuscitation, then follow up the job aid resuscitation and calling for help. After the baby is stabilized, basically never forget the clinical examination check for birth defects. Babies that need to be referred to SSNCU, they need to be stabilized before referral. So we recommend referring if less than 2 kilos, less than 34 weeks, and any neonate that is sick. Ensure that baby is warm before or during referral. Transporting skin KMC is ideal with the mother, father, or caretaker inside the facility, or for transports that are done through facilities. All airways are clear, the baby is well positioned and breathing. So transport with an oximeter and CPAP if needed, and if possible, if the baby needs CPAP, it would be the best way to start in the delivery room and to use an oximeter. If baby is stable, is fine, but ensure that the baby is stable in the cardiac point of view, meaning with a normal heart rate, 100 to 108 for a preterm. A little bit tachycardia could be acceptable, but not too much. That the baby has a CRT less than 3 seconds, that the baby has palpable pulse, so meaning you're not referring a baby that is in shock. And ensure that the baby is fed with colostrum in the first hour. So if the baby is gone to the SNCU a little bit later in the first hour, so please ensure that baby is fed before baby goes, or the baby goes with the colostrum to be fed in the SNCU, that the baby receives at least a small amount of colostrum in the first hours. And for babies that stay longer in the delivery room, to be stabilized, do not forget to monitor the random blood sugar. So always, this is very important, happening in many sites, that there is no communication between the SNCU and the delivery room. So this is a message that is important to reinforce. The SNCU inform SNCU staff at arrival of the baby, fill the referral note and the birth register, explain to the family the condition of the baby, and refer a sick baby with medical provider trained on resuscitation. So we also had some cases of babies being referred only with the parents. So it's important that they have a safe referral. So this is what this is about. So basically, we have this form later on we're going to share with you. And this is the form that we are going to be working on the next phase. I'll send the word back to Marian. Thank you.
Thank you, Flavia. So Flavia has explained about the job aids. We also do have some tools that we have, but I will not be showing it to you now. The two tools is one is with regards to the readiness tool, which basically looks at the infrastructure, supplies, etc. That would be required for SSNC. And the second is with regards to, I'll share my screen so that we can just run through it, and then I will. Okay. We have can you see my screen?
Yeah, we can see your screen, Marianne.
Yeah. So this is the readiness tool, which basically for care at birth, we're looking at
No, we can't
infrastructure.
see. We are seeing something else. Now we are seeing
You're
the
not seeing?
readiness tool. Now we are seeing the readiness tool. Yeah.
Yeah. So the readiness tool, where we're looking at infrastructure, equipment, supplies in the labor ward, and what Suman had spoken about with regards to the radiant warmer, air suction device, ambu bag, digital weighing scale, hand washing, adrenaline, and vitamin K injection. and in the OT as well, what needs to be there, and some human with regards to human resources. We will be going through this in detail later. And a strengthening tool, which will be part of y'all as mentors to be able to identify gaps in care at birth. So whether resuscitation equipment was well kept, birth companion available, immediate care at birth, immediate skin to skin contact, delayed cord clamping more than 1 minute, suction. There are certain aspects like suction of mouth and nose and oxygen given at birth. They are not to be done routinely, but we've kept them there to understand whether any practices need to be changed. Newborn bathed in the delivery room, again, a practice not recommended, and birth weight performed and recorded correctly. And this is additional with regards to an observation after in the first 2 hours of life, what needs to be done, whether breastfeeding was initiated in the first hour of life and birth register was complete. Plus, we are, as Flavia had already mentioned, we have the job aids. So job aids, one is on essential newborn care at birth, which Flavia explained. Neonatal resuscitation, we are not providing a job aid. We presume that all facilities will have your own national level protocol job aid available in the labor room and the OT. Birth companion allowed, a policy, whether there is a policy, and safe transportation. We will be explaining these tools to you, but just to make you all aware that these are some things that we will be doing in the project itself to be able to strengthen small and sick newborn care. With that, I think I will stop if there are no questions or no anything else, but just with a reminder that the next seminar will be on March 3rd. This will be on respiratory support, which we will be focusing on CPAP and safe oxygen use. We will be sending you, there will be a recording of this presentation in YouTube. I think we will be sending you the link for that. Those mentors who have not seen this particular, who've not attended the seminar, can probably view the YouTube recording to be able to understand basically the technical aspects of care at birth and the focus areas for small and sick newborn care with regards to care at birth. We've also prepared a mentor's manual, which we will be sending you in part. That is just the care at birth aspects, which you all can read. Flavia, would you want to explain further on with regards to how we would be following this up?
I think maybe we can leave this for the next seminar
Exactly.
or the next, because we are already 17 minutes past. And
Agree.
I'm sure all the mentors have a lot of activities still in their day. So, and definitely we also apologize for taking so much of your time, and thank you so much for staying with us up to now.
Yes, thank you all very much. And we assure you that all the other seminars will be on time, but today we wanted to spend time to at least see some of you all, and thank you for participating. This is the beginning of a journey together, which I'm sure will have great fruits for us and for our countries. Thank you very much for being part of this important journey. Bye, everyone.
Bye, everyone.
No
Thank
group
you.
photo.
Thank you.
Oh,
Thank you,
group
Suman.
photo,
Thank
yeah,
you,
group photo.
Flavia.
There are too many. We have 11,
Thank you, Dr.
11
Manna.
screens. So we have.
Thank you so much.
Thank you. Thank you.
Bye. Thank you.
Bye, everyone.
Bye, everyone.
Bye.
Yeah,
Bye.
okay. No.
Okay, goodbye.
Thank you, man.
Bye.
Thank you.